We're back with part 3 of acute kidney injury and chronic kidney disease, and we're going to go back to what our case scenario, kind of where we left off, and we were talking about the 78-year-old man who had surgery and then developed intrarenal AKA, most likely AKI, most likely from his gentamicin administration. And he's currently confused. So we know, okay, he's confused and his BUN and creatinine are elevated. And look at the potassium and look at the fact that he's had a 3 kilogram weight gain over the past 2 days. So what is the story? What should be done? Well, the patient has to stay in the hospital because he has hyperkalemia. His potassium is 6.5. And then again, your abnormalities included an elevated BUN and serum creatinine. And he also has gained 3 kilograms, which tells you that 3 liters of fluid has been retained over the past 2 days. So all of these signs and symptoms, when you put them together, they identify that he's got a marked decrease in his kidney function. The kidney is not doing what it's meant to do. It is not removing water or waste. And because he's retaining to fluid, he has the potential for volume overload. So it is most likely that at this point that probably the nephrologist was consulted, that the nephrologist is going to prescribe renal replacement therapy, RRT. And so what are some things, some criteria that would say, as far as the nephrologist goes, you know what, this individual needs renal replacement therapy? And when we talk about these things, this is kind of really for your information. Again, you know that it is the nephrologist, it is the physician that's going to make the determination to place an individual on dialysis. But you can kind of see from some of these things, from some of these criteria, that it really makes sense. And again, we look at what the kidney does. Well, if you're in a very acidotic state, then these individuals are going to have to need, or they're going to need renal replacement therapy. And intractable just means that no matter what happens, we can't seem to control the pH of the blood, and once the pH is either down too low or up too high, the cell will not function. And when I say cell, I mean heart cell, brain cell, anything will not function well. So we've got to get the pH within that normal balance. And the kidney is always responsible for compensation. And now you have the inability of the kidney to compensate because it's not functioning. E, electrolyte imbalance, we always think about potassium. I, and these are the vowels, A-E-I-O-U, help you remember this. Intoxicants, this is not indicated in this instance, but let's say an individual came in and they had a potential overdose, then sometimes renal replacement therapy will just be done because of their overdose. And then O, intractable volume overload, which is really looking like this guy has. He's gained 3 liters of fluid over a course of a short time frame, so he has intractable volume overload. And then uremic symptoms. He has elevated BUN and creatinine. His creatinine clearance by calculation is less than 15, and he has confusion and I think nausea and vomiting. So when we do RRT, renal replacement therapy, there are a few different options. And part of your criteria for this course is what are those options, and then what is the difference between the options, and include the potential complications. Now again, I'm going to try not to make this too wordy, because I don't know in how much detail you're going to have to go. So if you really feel like, I really didn't get enough information, then go back to your textbook, go back to your reading, go back to Dr. Reed's lecture, and kind of fill in the blanks where I've left off. But you can see that you have several options here. The individual can go on hemodialysis, they can go on peritoneal dialysis, they can get on the list for transplantation, for a kidney transplant, or they can refuse all care, withdraw care, and then just wait for that for their passing. So all of these are an option, and again, it's something that's going to have to be discussed with family or the patient depending on the situation. Now when we talk about hemodialysis, just like what it sounds, is this takes the place of a kidney. It does the job that the kidney will do, which is filter water and waste. And you can see, I've not put the big machine in here, but it's usually a big machine, but you can see that there is, you have to have some kind of access, and then the blood has to be pulled out of the body. Then it goes through this filter, which is basically the nephron, and blood doesn't actually touch the dialyzer, and then once it's dialyzed, then it goes back into the patient. And when we talk about hemodialysis, this is probably the most common in renal replacement therapy. The dialysis machine is usually referred to as the artificial kidney, but here's the main jobs of the dialysis machine. It is to pump blood, so it's going to pull blood out and pump blood back in, to watch the flow for safety, and then to remove waste and fluid from the blood. And here's the important piece: to watch the blood pressure. Because as you imagine, you're pulling quite a bit of blood out of the patient at a time. And so these individuals, you have to really very closely watch and ensure that the blood pressure stays stable. And of course, you can see that hemodialysis allows for the rapid removal of water and waste, and then also serum triglycerides can be low too. There is less protein loss in hemodialysis compared to peritoneal dialysis. We really kind of mentioned that already. Now, the dialysis solution is known as the dialysate. And really, as I said, it is basically like your own little chemistry set. It's all through osmosis, diffusion, water and waste will go through. The dialyzing solution never actually touches the blood, and the physician, the nephrologist, will provide a specific concentration of the dialysis solution depending on how much waste and water. And normally hemodialysis will last between 3 to 4 hours each session. And just like what we did, knowing that, hey, this patient's retaining water, what the nurse will do, the dialysis nurse will do, is they will weigh the patient before dialysis and then weigh the patient after. So in our instance, if we had our kilogram, our 80 kilogram man is what we want to get to, and he's 82 kilograms, well, we know that we need to remove at least 2 liters of fluid. And once he's done with dialysis, we need to get that 82 kilogram man, we should have him back down to 80 kilograms. And hemodialysis can be done either in the hospital or in an outpatient center. And here's some pictures of the different access devices, because hemodialysis needs a special access device. You can't just hook this process into a vein. You have to have a connection between the artery and the vein so that there's enough pressure or force behind it. And that is usually with an AV fistula or AV graft. However, these things take time to get ready or to cure. So if this is an acute situation, as in our case scenario where this individual was fine and then all of a sudden he's in intrarenal AKI, they're going to put what's known as a Grosjean catheter. It's a temporary access that goes in the vein, and you can see there's different colors to the tip, and so blood is going to pull through here, this portion of the port, and then go through our filtering process, and then we'll come back. Excuse me, this is going out, and then this is going to go, anyway, this is a weird picture, and I just goobered it up. Anyway, so you want the blood to go out, and then you want blood to come back in after it's been filtered. So prior to the initiation of hemodialysis, just like we said, you need a vascular access device. These Grosjean catheters can be inserted through either the internal jugular, subclavian, or femoral vein. And the problem with these is just like any other device, they can become clogged. Now, nurses are usually not allowed to use these for infusions of fluids, antibiotics, because they usually pack these things with heparin so that they don't get clotted off. And these devices can be placed at the bedside. Let's talk about complications of hemodialysis. Again, if fluid is pulled off too swiftly, then this can cause hypotension, muscle cramps, loss of blood, hepatitis, sepsis, and what's known as disequilibrium syndrome. Let me do a little bit more details about hypotension. So let's say you've got, over a 3-hour time period, you've got to get rid of 2 liters of fluid. And if you are dialyzing these individuals too quickly, then this can cause hypotension. So if the patient does become hypotensive, then you can slow the removal process down. And again, when you have an individual that first begins hemodialysis, these individuals should become or be NPO, because if they did suffer from hypotension, then that can cause a decreased level of consciousness. If it causes, and hypotension can cause nausea and vomiting, and so these individuals are at risk for aspiration. Now, if you've seen a dialysis patient that's been on dialysis for years and years and years, you'll go into the dialysis center and they're honking down the eggs and bacon and all this food, because it really doesn't affect these experienced individuals like it does the new individuals. Again, blood pressure control is very, very important in individuals on hemodialysis. Now let's talk about muscle cramps and loss of blood. Again, if you know, you saw that picture of the hemodialysis, you saw that there's this huge filter, and if for some reason during dialysis in the middle of it, that filter becomes clogged, then the nurse has to pull out the tubing and dump that filter in which there was a lot of blood. So these individuals can become anemic just from the fact of the process, and then on top of it, you're sucking this blood out and putting it through this filter. It can damage the red blood cells on a good day, and also that will cause anemia. And then also note that your kidney's not doing EPO secretion, and so all of those factors combined can cause anemia. Hepatitis, I think if you had an individual, this is not something that's common, but if you had an individual dialysis nurse that didn't cleanse the machine in between patients very well as not use a aseptic technique, then these individuals can get hepatitis and blood infections. Disequilibrium syndrome is caused when waste substances are removed more quickly from the blood than the CSF in the brain, because in other words, you rapidly pull off all these wastes, but the blood cell is like, well, wait a minute, I haven't had time to equilibrate or get back into normal. And so this can cause a fluid shift to go into the brain cell, and so this can cause cerebral edema. And just like as far as signs and symptoms of increased intracranial pressure from cerebral edema are going to be nausea, vomiting, headache, and twitching. Disequilibrium syndrome is usually seen with a new person on dialysis. Patients that have been on dialysis for quite some time, they seem to tolerate this disequilibrium a lot better. And then if an individual is very non-compliant with their medical treatment and they haven't been to dialysis for a week, usually dialysis is done 3 times a week, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, then once they're trying to get all of this waste off quickly, then it could occur even in a seasoned dialysis patient. Now, hemodialysis, as I said, it's usually about a 3 to 4 hour process. And if you think about it, you're going to take, let's just throw a number out. Let's say in our patient, we're going to pull 2 liters of fluid off in 3 hours. Well, if you had a patient that was hemodynamically unstable, in other words, an individual that had a very low blood pressure, if you pulled off 2,000 mils of fluid very quickly over 3 hours, these individuals would crash. So that's why sometimes the physician will do what's known as CRRT, continual renal replacement therapy. It is the same thing. It's dialysis. It's just done by the intensive care unit nurse. There's still a dialysis. A blood pump is going to pull it through the filter here, but it really can be used for unstable patients. And the critical care nurse does require training. It needs to have some kind of knowledge on how to run this CRRT. And so these individuals will get some training, but it's not quite as extensive as an individual that does hemodialysis hard, as in the 3 to 4 hour thing on a regular basis. Peritoneal dialysis, when you look at that, you can see that another type of renal replacement therapy is peritoneal dialysis, as catheter is inserted through the abdomen, and it goes and placed in the peritoneal cavity, and the tip of the catheter has many perforations, and then there's openings that allow for not only the insertion but the removal of fluid. Now the peritoneum is just like that membrane that was used. It's that round thing that we use, and so when we dump a whole lot of hyper concentrated solution, then what happens is through that peritoneal membrane, then fluids and waste will diffuse out. And so usually the fluid is dumped in there pretty rapidly, and then the fluid will do what's known as dwell time. It will sit in there for a while the chemistry set is in action with diffusion and osmosis, and then the bag will be turned taken down and turned upside down, and then the fluid will be removed. Now, peritoneal dialysis can be performed at home. You can use gravity, such as this picture here, or there is what's known as an automated peritoneal dialysis cycler. So a lot of patients that are outpatients really like PD because they can do it with the machine at home while they're sleeping. And so it doesn't interfere with their life. They can still go to work. They don't have to go to the dialysis center 3 times a day. And because they do it pretty much continuously, usually every night, then it's a little gentler on their body, and they don't feel this drained out whenever you suck off 2,000 mils in a 3-hour period. So it has some advantages, but the disadvantages are is you've got this catheter that's invasive, that's in the peritoneum, which is very vascular, and so you can get an infection if these individuals are not very savvy, or they're not very good about ensuring that they use aseptic technique when they're hooking in and removing the solution. You can get exit site infection. You can just get an infection. And so peritonitis, think about signs and symptoms of peritonitis: a lot of pain, rigid abdomen, decreased bowel sounds. So that would kind of, in a fever, and basically a patient that didn't look well. And it's a bad thing to get peritonitis. You can have what's known as poor inflow or outflow. In other words, if you're draining into the abdomen by gravity, if you have constipation, or the holes are stuck up against something, it may not inflow or it may not drain out. Either way, if you have 2,000 excuse me, 2,000 mils or 1,000 mils of fluid that goes in, you should have at least 1,000 that's coming out, if not more, because you should have water and waste that are being removed. So it's very important that these individuals kind of track what's going in and what's going out. Just like anything else, you can develop hypotension if that osmosis is doing super, super good and you're pulling off a lot of fluids. Malnutrition is because of the fact that you will lose protein in the hemodialysate as it drains, and so these individuals need to eat a increased amount of protein, and then of course it may not do its chemistry that it's supposed to do, and so they may not get rid of a lot of waste and water like they're supposed to, and then they may have to be shifted to hemodialysis. Again, this is the complications that are listed. The other thing, because we've talked about all of these, the other things that I want you to note is hyperglycemia can occur because most of the dialysate solutions are very hypertonic, which means they have a lot of dextrose in there trying to pull off that fluid. So if you have a diabetic patient, this can really cause problems with their glucose management, blood glucose management. Excuse me, the last thing we're going to talk about is renal transplant, and I'm not going to do a whole lot on this because we will talk about some specific things with organ transplant, but I just want to note, because this is something we don't think about, where these transplanted kidneys are placed. They're placed in the lower abdominal area, and these old and malfunctioning kidneys are not usually removed, and they place the new kidney down here in the lower abdomen. So any patient that comes in with abdominal pain that's had a kidney transplant is going to be assessed very closely and monitored very closely to see if there's some kind of problem with the newly transplanted kidney. Post-op considerations for transplanted is you really have to assess the urine output in the newly transplanted patient. You know, your kidneys have to have a lot of cardiac output, and so they really, really flood the kidneys with fluid. So these patients will be very hypervolemic because we really want to push fluids. And so as the kidney starts working and whatever they pee out, then that is usually returned mil for mil in addition to the normal amount of normal saline that's being infused. In other words, if 300 mils was the urine output on the last hour, then over the next hour you're going to use your normal amount of fluids plus the additional 300 mils. We really need to keep these patients well hydrated. Of course, we're going to assess the daily weight, vital signs, and then immunosuppression can be begun intraoperatively, and then it's continued for the life of the transplanted kidney. If you have any questions, please email me. This concludes the AKI CKD presentation.